All right, we'll get started. We will start with lecture 32, which includes exam 4 review. I feel like this module has been spread out over a long period of time, so make sure you go back and review everything we've talked about, including transfusion reactions, cross-matching, determination of hemolytic disease of the newborn, determining if mom needs ROGAM, and then autoimmune hemolytic anemia. At that lecture as well that we just did yesterday. So the exam is scheduled for Monday, April the 6th, and you guys can take it anytime you're ready, as long as it's submitted by 11:59 p.m. Central Standard Time. So what you can expect on the exam, there will be 72 questions, consisting of multiple choice, matching, true, false. It is worth 83 points. In your lecture manual at the end of this module, there is an outline that provides a review of topics. So make sure you pay close attention to that. There will be several questions regarding adverse transfusion reactions. So we're going to review some of those in this review, but make sure you go back and review those again, because I feel like it's been quite a bit of time since we covered that material. So be able to differentiate the symptoms associated with a febrile transfusion reaction versus an allergic reaction, and then those symptoms of a delayed hemolytic transfusion reaction as well, and be able to differentiate if that transfusion reaction is intravascular versus extravascular. And at the end of this lecture, we will go over some example questions on intravascular versus extravascular. All right, so you will have some IAT and DAT results to determine. So remember, this is mom and baby scenarios. So you always want to look at the mom's ABO, the mom's IAT result, the baby's ABO, and the baby DAT. Remember, if that baby DAT is positive, you do have hemolytic disease of the newborn present, okay? If mom's IAT is negative, that DAT in the baby is not positive because of a circulating IgG antibody in mom's plasma. It's probably due to ABO, okay? So you have to look at all of those test results in order to make those determinations. And so if you guys happen to have printed this presentation already, I did update it late last night. I added a lot of more content and examples to go over because I felt like this review was just very brief, and I wanted to make sure that you guys felt comfortable with this material. So I did include some examples. Hold on. So it looks like my examples are in a few further slides, so we'll get there. And then also, in the event that hemolytic disease of the newborn is present, if that baby is in severe respiratory distress and the symptoms of anemia, there could be the potential that an intrauterine transfusion needs to be performed. And so make sure that you are aware of those donor requirements. Remember the blood product requirements for our neonatal transfusions and our intrauterine transfusions. Remember that the anticoagulant of choice should be CPD, CPDA. We should never use Adsol as the anticoagulant or preservative added to that unit because it is toxic for these neonates. So never use Adsol. We want to use the anticoagulant CPD. It should be fresh. Remember that those red cells should be between no more than 5 to 7 days old. The unit should be radiated and leukodepleted, okay? And then also remember some of our transfusion reactions. If you do expect a hemolytic transfusion reaction caused by intravascular hemolysis, such as a wrong ABO type giving, remember what's going to happen is those cells are being lysed intravascular at a rapid pace. So you're going to have increased bilirubin, decreased haptoglobin. Patient could go into renal failure, could go into shock, and then ultimately could lead to death. What your patient is going to feel, the symptoms, they're going to complain of flank pain. So they're at their back, right at the kidneys, they're complaining of pain there if it was a intravascular hemolytic reaction, such as due to the wrong ABO. They might have shortness of breath. They might break out in a sweat. So these would occur immediately, all right? So these symptoms are going to occur immediately. So when we study moms and babies, moms who are Rh negative are given a antenatal dose of Rogan at 28 weeks. That is considered passive anti-D. So in BloodBank, we have to differentiate passive anti-D from true anti-D. And one way we do that is through titering. So usually if it's anti-D due to Rogan administration, that titer is going to be low. It'll usually be 1 to 8, all right? So typically if it's true anti-D, that titer will be greater than 1 to 32, okay? So mom is actively building anti-D. Rogan results in a lower titer because that's passive immunity rather than active. And then remember, when we do a DAT on a baby, we will use polyspecific AHG, just because mom's maternal ABO antibodies have the capability to be IgG, and then we also want to be able to detect activation of complement as well. So we want to use polyspecific with the AHG. Make sure you can determine plasma and cell requirements for a recipient. So if your patient is AB, make sure you are familiar with what type of blood products they can receive. So red cell components for a type AB. AB patients are considered the universal recipients, so they can receive A, B, AB, and O. However, for plasma products, they should only receive AB plasma. Okay, so you have to think about where the antigen is and where the antibody is. Versus, let's look at a type O patient, could be transfused only type O red cells, but on the plasma, they could be transfused any type of plasma, okay? So it's kind of reverse. You have to think about if you're transfusing red cells or plasma products. And remember, for platelets, we typically do not worry about the RH, or in plasma, we don't worry about the RH either, because remember that D antigen is on the red cells. So we only worry about RH compatibility for red cell components. And then for platelets, sometimes the ABO is overlooked as well. So it's possible if you start working in a blood bank hospital that they will give a patient type B platelets, and that's possible as well. Now, in the event your patient becomes refractory, meaning that their platelet count does not increase, then we might want to try to give ABO specific platelets. All right, so if a warm auto is present, how is it detected? Remember, warm auto indicates that your patient's cells are coated with an IgG antibody. So the DAT is going to be positive. It will be positive with polyspecific. It will also be positive with monospecific IgG. And it could be positive or negative with complement. And then, so your auto control will also be positive. Your panel cells are all going to be pan-reactive at the AHG phase. So remember how you can differentiate a cold autoantibody from a warm autoantibody is the phase of reactivity. So a cold autoantibody will have pan reactivity at initial spin and then will dissipate upon warming to 37, a warm autoantibody, you will have, your reactions will be only at 37 and or AHG phase of testing. Okay, so remember how we differentiate a cold from a warm. And remember how a donor with a positive DAT, how that affects our cross matches. So think about your major cross match. You're mixing patient plasma or recipient plasma, if you want to think of it like that, with donor red cells. And so think about what's happening in a DAT, or in a DAT. The donor has antibody that has attached to the donor red cells in vivo, all right? So something's going on inside that patient causing antibody to attach to those donor red cells. So when we do our cross-matching in the AHG phase of testing, that monospecific IgG AHG reagent is going to bind to the IgG antibody that is coating the donor cells. That will cause an incompatible cross-match at AHG. So if you are performing cross-matches on your recipient and a cross-match pops up positive unexpectedly at the AHG phase of cross-match, we always want to suspect that the donor could potentially have a positive DAT. Now, what should you do with that unit? If you do determine that that unit has a positive DAT, it should be discarded. It is not safe for transfusion. If it is transfused, it could cause harm to the recipient. It could attack those antibody-coated cells. So if a unit is mistyped, how does this affect a cross-match? So if a unit is mistyped, so let's say your recipient is type O, and then you have a type A unit, maybe it's a weak subgroup of A that was mistyped as an O, but really it's an A, and you try to give it to this O patient, that will cause a 4+ reaction at initial spin, all right? So anytime you have a mistype unit or ABO incompatibility between your donor and your recipient, our cross-matching results will be very strong, positive, okay? Those IgM antibodies are immediately going to attack those donor cells, all right, in a cross-match. So, and not only you'll first see it at initial spin, but if you were to continue to carry that cross-match through each phase of testing, it will also remain positive at each phase of testing. And in a later slide, I have an example where we're going to look at that, all right? So you would definitely have very strong agglutination incompatibility. What does a look back mean? So the term look back really means you're thinking about the donor collection process. And if you have a donor that is a repeat donor, so has multiple donor histories, and then they donate, and at that particular donation, they end up testing positive for an infectious disease, whether it be HIV, hepatitis B, hepatitis C. At that point, they are considered positive. A look back, you have to go back into that donor history, figure out all of their previous donations, and figure out the status of all of those units. Which hospital did it go to? Who was the recipient? And then all of those recipients have to be notified that that donor now has tested positive and that they could potentially have been infected at that time. That's the look back. It's part of the quality assurance program built in all of blood banks, especially if you're at a donor collection center. And this says, who received the blood of an HIV. I want to make sure it's not only HIV, it's all infectious disease. All right, so anytime you have a repeat donor test positive, then you have to do a look back at their historical previous donations and do an audit on each of those units. What could happen if the wrong patient receives blood? Well, the huge concern there is ABO incompatibility could cause a intravascular hemolysis, could result in death. All right, so how is blood issued in an emergency situation? So in an emergency situation, whether it be in the operating room or in the ER, if you do not have a current sample on the patient, you do not have a type on file, we will always try to give O negative red cells. And these would be uncross-matched emergency release units. Now, if your patient is in childbearing age and a female, then we always want to try to provide Rh negative units. However, in an effort to conserve our O negative units, and especially if they're going through a lot of products, which can happen in trauma situations before we receive the sample and get a type on the patient, if it's a male or a older female out of childbearing age, then we can give O positive red cells. Those, I want you guys to understand, those are uncross-matched emergency release. The physician has to sign a waiver saying that he is taking responsibility for those uncross-matched units to be transfused. And then what's going to happen is, once BloodBank does receive a sample, we must do what we call post-cross-match. So we still have the segments from those units that were transfused. We will use those segments to perform the major cross-match with the patient. And then those results must be entered into your BloodBank management system. And so that's what we call the post-cross-match. And so a lot of people ask, well, what's considered childbearing age? So any time between the age of 12 and 51, all right, is really considered childbearing age. And then what's the purpose of irradiation? Remember, irradiation will prevent those mature lymphocytes from proliferating in the recipient, all right? So it prevents graft versus host disease. And then remember the purpose of leukodepletion. Leukodepletion gets rid of all of the white cells except some of those mature lymphocytes that are able to make it through the filtration process, and it prevents the transmission of CMV, and also it reduces the exposure of the recipient to HLA antigens as well. And then who should receive irradiated blood? All right, so anytime you have a directed donation and it's going to, and the recipient is a first-degree relative, that product should be irradiated due to the similarities of the HLA and the recipient not recognizing it as foreign, but could still launch an immune response against the recipient. So all products from first-degree relatives must be irradiated. Any patient that is considered immunocompromised must receive irradiated products as well. That includes our neonatal patients, as well as bone marrow transplants, as well as any type of cancer diagnosis. Those patients are considered immunocompromised. And if a intrauterine transfusion is being done, that product needs to be irradiated as well. So if you have a patient who has anti-I and KEL, what phenotype should be given, and then what other precautions would BloodBank recommend? All right, so your KEL antibody, and this all goes back to knowing what classification of your antibodies are, and which one are considered clinically significant, all right? So KEL is a IgG antibody capable of causing hemolytic disease of the newborn, capable of causing transfusion reactions, so it is considered clinically significant. So if a patient has anti-KEL, it's very important that we provide KEL negative units for transfusion. Now anti-I is a IgM room temp reacting antibody, and it is documented that if you have cross-match compatible blood, there's no reason to phenotype for the I antigen. However, because it is a cold reacting antibody and it can interfere with our back typing and react at initial spin of the IAT, we will recommend the use of a blood warmer, all right? So if you have anti-I that is reacting at a room temp and then dissipates at 37 degrees, that mimics what's going to happen inside your patient body. So in order to avoid that, we will recommend the use of a blood warmer for transfusion. So anti-Kel and anti-I, we want to provide Kel negative units and then recommend the use of a blood warmer during the transfusion process. There is no need to antigen type for anti-I or the I antigen because 99.9% of the adult population is I positive. All right, so it's a cold reacting anti-I auto antibody. That's what I'm trying to say. And so be able to identify ABO HDN and RH HDN. Look at examples in your notes, and I included some examples here just for us to go over a little bit further. So the way to approach these hemolytic disease of the newborn cases, number one, always look at mom's type. Remember, if mom's type is O and the baby's type is either A or B, there is the potential for hemolytic disease of the newborn due to ABO incompatibility. If mom is a type other than O, and she's Rh negative and her IAT is positive, that could indicate the presence of a non-ABO circulating IgG antibody present in mom. So whatever antibody is identified in mom's plasma could be attaching to the baby's cells if baby is antigen positive. Okay, mom's IgG antibody is able to cross the placenta and attach to baby cells. All right, that would cause symptoms of anemia in the baby as well as resulting in respiratory distress in the baby. Okay, I mean, remember, anti-D is the most common cause of hemolytic disease of the newborn, followed by little c and Kel as well. Those are our most common culprits in hemolytic disease of the newborn. But any other clinically significant IgG antibody can as well, Defi A, Defi B, JKA, JKB, all of those antibodies are capable as well. So let's look through these examples. And the first one here, mom is O negative, weak D negative, IAT negative. So because mom's IAT is negative, we know we are not dealing with a red cell antigen that is non-ABO, all right, because mom's IAT is negative. Remember, babies do not produce antibodies until about 6 months of age. So the positive DAT in the baby has to come from the mom, okay? And then so if we look at baby type is A positive and the DAT is weakly positive. Like I mentioned earlier, anytime you have a positive DAT, that indicates that hemolytic disease of the newborn is present, okay? And we want to be able to differentiate ABO HDN from IgG HDN, another IgG antibody other than ABO, okay? So remember, the concern for these type O moms, they have anti-A, B that is of the IgG classification and can cross the placenta. And then sometimes, even low titer amounts, you might even have anti-A or anti-B cross the placenta as well, all right? So that's what causes the ABO hemolytic disease of the newborn. So in this case, because the DAT is positive and mom is type O, baby is type A, we would classify this as a hemolytic disease of the newborn due to ABO incompatibility. We would definitely want to confirm that with a Louis freeze to see what the eluate reacts with, because that would differentiate if it's A, B that's coding the cells, or maybe it's just anti-A coding those A cells. And then RhoGAM. Remember, all Rh negative moms, regardless of what type the baby is, will receive a perinatal dose of RhoGAM, 1 vial at 28 weeks gestation, all right? Post-delivery, if mom is Rh negative and delivers an Rh positive baby, then the postnatal RhoGAM dose must be given within 72 hours of delivery, okay? So that 28 weeks dose of RhoGAM is given to all Rh negative moms because we don't know the type of the baby. All right. After delivery, if the baby is Rh positive, mom will get an additional dose of RhoGAM. Now, you will have some clinicians that, regardless of the type of baby, the Rh of the baby, they will want to transfuse RhoGAM to those moms, even if the baby is Rh negative. And one thing about RhoGAM, it won't hurt. So if they want to give it, might not be clinically warranted, and it might be an additional cost for the patient, but some clinicians will want to do that, just a heads up. But literature states that only if the baby is Rh positive does that postnatal RhoGAM need to be administered. All right, so here's another example. Mom is O negative, weak D negative. All right, so mom is O, so we do have the potential for ABO incompatibility there, but also her IAT is positive, so we do have the presence of an antibody. And then the panel identification reveals anti-D, which is titered at 256, which is very high and very clinically significant. So if we look at our baby type, our baby is typing as A positive, and our DAT is 4+. So what's happening here, see how strong that DAT is? So we definitely have a case of hemolytic disease of the newborn in the baby. And because it's so strong, remember, one of the characteristics of differentiating ABO HDN from IgG HDN is the strength of the DAT. In ABO, as we saw in the first example, the DAT was very weak. This example, which has a anti-D IgG antibody involved, is very strong, 4+, right? So that's another differentiating factor between ABO and non-ABO IgG HDN. All right, so this baby has hemolytic disease of the newborn due to anti-D because mom already has built the active anti-D. She does not need RhoGAM. Okay, there's no need to give her RhoGAM. She's already built the antibody. Okay. The next example, mom is O negative. Weak D, we have a mixed field reaction. Her IAT is negative, and we have a positive fetal screen. So remember what the fetal screen indicates. Mom is supposed to be Rh negative, right? But when we do our fetal screen, the fetal screen detects the presence of Rh positive cells that would have came from the baby. So mom has baby cells in her circulation. The problem there, if mom is Rh negative and is exposed to the D antigen, she could potentially build anti-D, all right? So the problem in this scenario is not baby, okay? Look at baby. Baby is A positive, DAT negative. There is no hemolytic disease of the newborn in this case. The problem is mom, who has experienced a fetal maternal bleed and now has fetal cells in her circulation, has the potential to build that anti-D, all right? So following that fetal screen, we need to do a Kleiheuer-Betke to quantitate the amount of that fetal screen or that fetal bleed and determine mom needs additional vials of RhoGAM in order to clear that bleed. Okay, that's what the fetal screen indicates. The fetal screen is not quantitative, it just detects the presence of Rh positive cells. And this bleed is significant enough that it's even affecting mom's weak D testing as well. And that's why we're getting a mixed field agglutination. All right, so let's take this case a little bit further, and let's go ahead and do our Kleiheuer-Betke test. So we have the mom from the previous example who had a positive fetal screen. We're going to do that Kleiheuer-Betke, and while we're performing that Kleiheuer-Betke, we notice 6 bright pink cells when a total of 500 cells are counted. So remember, those bright pink cells, those are your fetal cells. That's your hemoglobin F. And remember, during the acid treatment of the Kleiheuer-Betke, the hemoglobin F is resistant to that acid treatment. So normal adult hemoglobin A is precipitated out, leaving the ghost cells hemoglobin F remains the bright pink cells, okay? So if we have 6 bright pink cells per 500, remember this calculation, all right? Calculating the number of vials needed. So you take 6 divided by 500, and that gives you 0.012. You can leave it in the decimal, or you can convert it to a percent. If you convert it to a percent, the next step, you would only multiply by 50, all right? But I want you guys to know where that 50 comes from. There are, at any given one time, 5,000 mils of blood in your circulation, okay? So we're saying 1.2% of that blood in this mom is fetal cells, right? So we're going to convert that into mils. And so then we end up, mom has 60 mils of fetal cells in her circulation right now. Remember, 1 30 microgram vial of RhoGAM will clear a 30 mil bleed or 15 mils of red cells, okay? So you take the amount of fetal cells in mom's circulation, so right now we have 60, divided by 30, all right? And so in this situation, we get 2. Remember, if you got a decimal point to round up or down, all right? So if it's greater than 0.5, round up, and if it's like 2.1, you could leave it at 2, and then add 1, right? Do not forget to add 1 here. This accounts for any room for error, all right? So this would be 3 vials of RhoGAM needed to clear the 60 mil bleed during this fetal maternal hemorrhage that occurred in this mom, okay? So you guys make sure you are comfortable with this calculation, make sure you know it, not only for this exam, but also your board of certification. All right, the next example, mom is O negative, week D negative. She has a positive IAT, antibody identification again yields anti-D with a titer of 256. That's a very high anti-D titer. The baby is probably in definitely respiratory distress. When we type the baby is A negative. Take a look at our week D. The week D on the baby is invalid. So remember that invalidates our RH. And remember some possible causes of that. And okay, I'm gonna come back to that. And notice too that the baby has a DAT, a positive DAT, indicating that there is hemolytic disease of the newborn present. Okay, that week D invalid, let's talk about what's happening there. Mom's anti-D is crossing the placenta, coding all of the antigen sites on the baby cells. So the baby is actually RH positive, but because of the such high titer of anti-D, all of the D antigen sites on the baby red cells are taken up by anti-D. So there are no available D antigen sites binding left for our reagent to bind to. So that's why upon initial spin, we get a negative reaction, and then in our week D testing, we have a positive RH control, okay? So one thing that you would have to do in this scenario is you would have to do an elution, a glycine EDTA treatment, which would, on the baby cells, would pull off that anti-D, saving the red cells. So the red cells are still viable. That's what we want, because that's what we need to test in order to obtain a true RH antigen typing on this patient, on the baby, okay? So we do glycine EDTA treatment. It's gonna remove mom's antibody from the cells, making those D antigen sites available, which will now bind to our D antisera, and we can determine that this patient is A positive, all right? That glycine EDTA treatment removes the antibody, causes the DAT to now be negative, and we can obtain that true ABO type. And Sarah asked this, is this the block D phenomenon? Yes, this is the block D phenomenon occurring when mom's anti-D is so high like this, all right? So remember in the previous example, This example, mom had such a high anti-D titer, but we obtained an A positive typing on the baby. So it didn't cause a problem here. And I want you guys to understand this doesn't have to always happen. It just has been observed and has the potential to occur. And I want you guys to understand that hemolytic disease of the newborn does not always happen either. You can have an O mom that has an A baby and not hemolytic disease of the newborn doesn't occur. It just is, it can occur, has the potential to occur, and BloodBank will always be on the lookout and be able to diagnose these situations. All right, so this is the block D phenomenon. Baby does have hemolytic disease of the newborn due to anti-D. And then because mom's anti-D titer is so high, it is coating the baby's Rh positive cells. And a good way to identify this right off the bat is when you are doing your week D testing on your baby, your week D tube is going to be positive as well as that Rh control. So then you're going to have to do some further investigations. All right, so here's our last example. We're given mom results at 28 weeks of gestation, O negative, week D negative, an IAT positive with an anti-D titer of 1 to 8. All right, so mom at 28 weeks, we have to think about that anti-D titer. Is that true anti-D or is it passive anti-D? And so mom at 32 weeks, so 4 weeks later, we're repeating that ABO testing on mom, O negative, week D negative, but notice her titer is going down. So we can assume that that reaction is due to the administration of RhoGAM. Okay, if this was true anti-D, the titer would consistently be going up and would be more stronger. All right, passive anti-D, such as from administration of RhoGAM, causes the titer to be weaker and it is continuously going down because it's cleared from the maternal circulation quicker. All right, so you guys spend some time on those hemolytic disease of the newborn and RhoGAM cases. Review those, make sure you feel comfortable with that. Remember, look at mom's ABO, baby's ABO, look at mom's RH. If she's Rh negative, always keep the potential for anti-D, which would be identified in the IAT and panel identification. So you have to take into account all of that information when doing mom and baby cases. All right, so what product should be given if the platelet count is normal, but your PT and PTT is increased? So the appropriate product would be fresh frozen plasma, remember, because it contains all of the coagulation factors. So if the baby is Rh positive, DAT is negative, mom is Rh negative, IAT is negative, is this the presence of hemolytic disease of the newborn? And remember, in order to answer that question, you want to look at the DAT. So even though mom is Rh negative, baby is Rh positive, that DAT on the baby is negative. So there is no case of hemolytic disease of the newborn in this situation. Could someone who is healthy, hematocrit of 38%, give blood for an autologous donation? Yes, the answer for that is yes. Can platelets be contaminated by bacteria? Remember, platelets are the #1 product that is most often associated with bacterial contamination because they are stored at room temperature. And then which hepatitis can be contracted from a transfusion? Remember, hepatitis B and C are the ones we worry about with being transmissible through a transfusion. Hepatitis A and E are from the fecal oral route, all right? And then remember, hepatitis D usually occurs as a co-infection with hepatitis B. So by testing for hepatitis B, we also include hepatitis D there. And remember, hepatitis B is the one that is more commonly transmitted. Can HIV be transmitted by pooled cryo? So the concern here is that you are pooling the product meaning that you are combining multiple donors. So the risk for transmissible transfusion of infectious disease is increased because you're being exposed to multiple donors in one transfusion. So the answer here is yes. And then again, HIV, pooled products, yes. So what amount of blood loss can occur and the patient still feel well? So you guys remember we talked about the presence of blood loss, and I included this chart just for your reference. So think about when you go and donate a unit of blood, they usually take about 450 to 500 mils. Usually that results in minimal symptoms, okay? So that's usually the amount of blood that you can lose before experiencing any other symptoms from that blood loss, all right? So 500 mils. If you lose more than 500 mils, your heart rate starts to increase, your blood pressure can drop. If you lose 1,500 mils or 30 to 40% of your total volume, your pulse will go up. You could have a hard time breathing, cold, clammy skin. And then if you lose greater than 50% of your blood, you could go into organ failure, unconsciousness, and that could result in shock and death. All right, and then also remember what happens during acute blood loss. So your body's going to try to compensate for that blood loss, and it's going to pull the fluid from the extremities to the core. All right, so the blood is directed to the core, not to the extremities. All right, so could you see that being a really good true and false question? Yes. What adverse reaction is experienced during apheresis that is unique to apheresis? So this is citrate toxicity, which if you were donating platelet apheresis and they take the product and they treat it, they're going to add anticoagulant to it and then give that product back to you. So you are receiving a lot of citrate, which can bind to your calcium, cause hypocalcemia, and result in tingling of the lips. And then the way they usually treat that is with oral calcium or Tums. And what blood type should be given if the blood type changed after a bone marrow transplant? All right, so if you guys remember when we talked about bone marrow transplants, there were several different categories, but depending on the type of incompatibility. Is it a major incompatibility versus minor incompatibility? So the type of blood is determined, that should be administered post bone marrow transplant is determined on the type of incompatibility and the DAT as well. So I included this chart here. So remember, in a major incompatibility, you have your recipient antibodies that is going to attack the donor cells, right? So you will have some hemolysis, so you will have a positive DAT. And then in minor incompatibility, you have your donor antibodies will attack the recipient cells. So you'll also have a positive DAT. All right, so the product determination, we always want to look at when our patient changes type. So notice pre-transplant, transplant, and then at the time where your recipient antibodies are no longer detected, we can start giving that recipient the donor type. Okay, so that's for a major incompatibility. A minor incompatibility, notice that we can still give O. And what most hospitals are going to do is they will probably always try to give O red cells for these bone marrow transplants. That's always the safe route. And so what are some examples of immune transfusion? So a febrile non-hemolytic transfusion is an example of an immune. Febrile is immune, allergic is immune. And so if you guys remember, I have a chart coming up that will further differentiate that from immune versus non-immune, acute versus delayed. Okay, so we'll talk about that in just a little bit. What's an example of a delayed adverse reaction? So think about transmission of infectious diseases. We won't know that immediate. So remember, most of our acute transfusion reactions occur at the beginning of that transfusion or during that transfusion. However, if it's greater than 24 hours post-transfusion, that is considered a delayed reaction, right? So transmission of infectious diseases, or such as a delayed hemolytic transfusion, such as we see in with our kid family antibodies. All right, and so then identify cross-match discrepancies. And I wanted to go over these. These are taken from your lab. I think it was lab 9. And so I wanted to spend some time going over these just to make sure that you guys understand the difference between compatible versus incompatible and what can cause cases of incompatibility. All right, so when you approach these cross-match interpretations, you want to make sure and look at your patient ABO. Was there any type of discrepancy present? Take a look at your patient IAT. Is there an antibody present? And then look at your cross-match results. What phase is it incompatible in? And then what can cause incompatibility at that specific phase. All right, so let's look at patient number 1. His front type is a O positive. His IAT is positive with screening cell 2 at the AHG phase. His autocontrol is negative, so we know we're not dealing with a autoantibody. And then we cross-match 2 units on this patient. Notice that anytime you have a positive reaction, you have agglutination present in your cross-match, that indicates incompatibility, all right, at any phase. So if it's positive at initial spin, that unit is still considered incompatible. All right, so notice the first unit, 5692, is incompatible. We have a positive reaction at the AHG phase of testing. If you notice, it is the same phase of reactivity and the same strength as our reaction with screening cell 2. So unit 5692 is incompatible due to the unit is antigen positive for the patient's corresponding antibody, okay? And so that's kind of how you have to approach these cases. You have to look at your IAT. If an antibody is present and your unit is not antigen negative, that will cause incompatibility, all right? And then the second unit, 3645, is compatible. We have negative reactions across the board. All right, the next patient, front types as an A, back types as an A, and RH negative. So this patient is A negative with a negative IAT, so no unexpected allo antibodies present. Unit number 0978 is negative at all 3 phases, so that unit could be considered compatible and safe for transfusion. However, unit number 3756, notice how strong this reaction is. 4+ at initial spin. If you have a 4+ reaction at initial spin, your first automatic thought should be ABO incompatibility. All right, so our patient is A negative. This unit is probably a B. All right, so this 3756 unit incompatible due to ABO incompatibility. And notice that that ABO incompatibility carries through all 3 phases of testing. It's positive 4+ at initial spin, 37, and AHG, okay? So let's look at the next example. Our patient is B, all right, forward and back type match, but notice we actually have a positive RH control, and then we have a positive auto control at the AHG phase of testing. So what do you think in this patient, what would cause the positive RH control and the positive AHG? I'm thinking this patient has a positive DAT, all right? So remember, because we have this reaction at AHG, that 2+ reaction, probably this patient has a positive DAT, but notice the cross matches are compatible, right? So that's something to note. When your recipient has a positive DAT, it doesn't affect the cross matches, okay? When the donor has a positive DAT, that's when it could cause incompatibility in our cross matches, okay? So this is a really good example of a recipient having a positive DAT. All right, so the next example, our patient is AB positive, forward and reverse typing match. If you take a look at the IAT results, notice that we have 3+ reaction with screening cell 1, screening cell 2, and the auto control. So this patient has a warm auto antibody, all right? And then we will also see that in our cross matches, unit number 0587 and 8730 are both incompatible at the AHG phase of testing. Same strength as our IAT. So this incompatibility for this patient is due to the warm auto antibody. All right, and then the next patient, O negative, negative screening cells, but then unit number 3894 pops up positive at the AHG phase of testing. This could be 2 reasons. One, could have a positive DAT in the donor, or number 2, your patient has a antibody to a private antigen that is not included on the screening cells, but this unit happens to be positive for, right? That's another possibility. And what you would want to do here is we could do a DAT on this unit to test that. So anytime you have an unexpected incompatible cross match, we want to investigate why. Does our patient have a circulating allo antibody that wasn't detected, or is it a positive DAT in our donor? And then the next patient, we have A positive with a negative IAT, but notice that we have both units that were cross-matched popped up incompatible at AHG phase of testing. So what could possibly be happening here would be both of these units might be positive for a private antigen that we did not detect on the IAT. I would suspect it's very rare to have 2 units that pop up like that. It could be that both of these units have a positive DAT. Again, for both of these units to be positive, I think that would be a very rare case. Usually if you have a positive DAT or an antibody to a rare antigen, then usually one would be positive. So in this case, definitely involves some further investigation, but probably both of these units are antigen positive for an antibody that was not identified on the on the IAT. In our next example, we do have an ABO discrepancy. Notice that our patient is front typing as an A positive, but back typing as a O. All right, and notice this 1+ reaction with the A1 cells. So we might suspect that this patient is a A2 with anti-A1. Now we're not given A1 lectin results or A2 cells, but so that's just making an assumption. But if you notice, unit number 3965 is negative at all 3 phases of reactions, so it's compatible. However, unit 6829 with the 1+ reaction at initial spin, so that's a room temp reacting antibody in the patient's plasma, and if we said that she's A2 with anti-A1, that anti-A1 is a room temp reacting antibody. So this unit 6829 is probably A1. And so this is what you would see if you try to transfuse an A2 with anti-A1 patient with an A1 unit. And so that's what's happening in this scenario. And then our last scenario is front typing as an O positive and back typing as an O, so there's no discrepancy there. Screening cell 1, screening cell 2, and the autocontroller all positive at initial spin, indicating the presence of a cold autoantibody. And that carries through the cross-match. Unit number 2386 and 4936 are both 2+ reactions, so the same reaction strength that was in our IAT, indicating that that cold autoantibody is interfering with our cross matches. All right. Sarah asks for Cox, Mary, it would be okay to transfuse either donor unit even though the patient has a positive DAT. So because before she can be transfused, blood bank would definitely need to do more further investigation on Mary Cox, because we have a RH invalid here, and then she also has a 2+ reaction at her auto control. So we would definitely have to do a DAT and figure out what exactly is coating her cells, what antibody. And then if we identify a specific antibody, we would definitely need to make sure that these units were antigen negative. So she can be transfused. We just need to honor whatever is causing her positive DAT. And so if these are compatible, more than likely, they probably are also antigen negative for whatever's coating her cells. So we would just want to make sure that they're antigen negative. We would want to do that DAT and an elution if necessary. So further testing on Mary Cox. Good question, Sarah. Thank you. All right, so when you think about a patient having a bone marrow transplant, is it better to honor HLA or ABO? So if you think about it, patients that are receiving bone marrow transplants, allo bone marrow transplants, so from a another donor, right, other than their self, so this is not an auto bone marrow transplant, this is an allo, HLA is more important than ABO, right? So for bone marrow, HLA match is more important to guarantee successful of the host accepting that bone marrow. And this is why oftentimes we will see after a bone marrow transplant that patient's ABO start changing because that bone marrow donor was of a different ABO. Oh, sorry, that question was from Fiona. Sorry. Good question, Fiona. And so what are the consequences of a delayed hemolytic transfusion reaction? So remember, a delayed hemolytic transfusion reaction, and we're thinking about such as we would see in the kid antibodies. So what's going to happen is maybe 5 to 7 days later, the patient's going to present with symptoms of anemia. They're going to have a decreased hemoglobin and hematocrit, decreased haptoglobin. And then this is due to extravascular hemolysis, all right? So what's happening is during initial blood bank testing, that anti-JKA or JKB, the titer was so low that it was at undetectable levels, and so blood bank wasn't able to identify it. But when that patient was transfused, amnestic response, that patient's titer is going to strike up and then start attacking those donor cells that are JKA or JKB positive. And then the antibody-coated donor cells are going to be taken out by the patient's spleen. So that results in extravascular hemolysis. The patient will have a decreased hemoglobin, decreased hematocrit, symptoms of anemia. And because of that excess extravascular hemolysis, increased bilirubin as well as the decreased haptoglobin. So the P24 HIV testing that has been incorporated into our donor testing has that completely eliminated the window period. So while that has reduced the window period, it is not completely eliminated yet. We still have a window period for all of our infectious disease testing. While nucleic acid testing has drastically reduced that window, we do not have a 100% infectious disease identification process yet. So there is still that window, and make sure you guys understand what the window period means. The window means from the time the patient becomes infectious until our testing capabilities are able to detect the presence of that infectious disease. And then should a mom who is D negative, weak D positive receive RhoGAM, she is considered Rh positive. She does not need RhoGAM. If a patient is experiencing platelet refractory, will irradiating the unit be required? So if you guys think about platelet refractory, that means that a patient is transfused platelets and their platelet count does not increase as expected. So that means the patient might have a platelet antibody that is attacking those donor platelets, therefore preventing those platelets from surviving. And so that could also be an HLA antibody. So irradiating is not the appropriate therapy of choice in that situation. A better option would be to provide cross-match platelets or HLA platelets. And then some adverse transfusion reactions, and I included some additional charts here just so you guys are aware of transfusion reactions. Anytime your patient spikes a fever greater than 1 degree, or it increases greater than 38 degrees Celsius, your patient complains of chills or rigors, any type of respiratory distress, any change in their blood pressure, any type of pain, whether that be pain at the site of infusion, flank pain, chest pain, back pain, those are all considered symptoms of a transfusion reaction. Any type of rash, any type of swelling or edema, jaundice, hemoglobinuria, nausea, vomiting, mucosal bleeding, anything like that is indicative of a transfusion reaction, and the transfusion should be immediately stopped and investigated. We want to figure out why. Right, so here's the difference between an acute, delayed. Remember, symptoms of an acute transfusion reaction usually occur at the very start of that transfusion or sometime during that transfusion, versus a delayed transfusion reaction occurs greater than 24 hours later. And some examples of acute would be a hemolytic immune transfusion reaction, a febrile, non-hemolytic, allergic versus anaphylactic, and then trolley. Those are all immune mediated, meaning that the body launched an immune response, versus non-immune would be the unit was contaminated with bacteria, or remember we talked about TACO being a circulatory overload, or the presence of hemolysis in that unit. And then delayed immune would be a delayed hemolytic transfusion reaction such as JKA and JKB. Graft versus host disease is immune, but symptoms do not appear until days later. And then some non-immune delayed hemosiderosis for those patients that are transfused multiply, like sickle cell and alpha thalassemia, and then citrate toxicity for those apheresis patients. And then I included this chart to differentiate, further differentiate between acute and delayed. Notice in acute hemolytic, when we are doing our transfusion reaction workups, we will always pay attention to the DAT. So if you have a febrile non-hemolytic transfusion reaction, due to HLA antibodies, your DAT is probably going to be negative. All right, versus if you have an acute hemolytic transfusion reaction, such as seen in the transfusion of the wrong ABO, then it could, your DAT would most likely be positive. All right, so in a transfusion reaction, that DAT is very important. And then notice in a delayed hemolytic transfusion reaction, your DAT is positive, okay? And so I included this chart here just so you guys recognize the difference and causes of a febrile non-hemolytic transfusion reaction. It's febrile, meaning that your patient develops a fever, but there are no symptoms of hemolysis occurring. And the most often reason for these febrile non-hemolytic transfusion reactions is the HLA antigens that are found on the white cells. And now by offering leukodepleted products, the occurrence of febrile non-hemolytic transfusion reactions has drastically decreased. And you could also prevent or pre-treat these patients that are known to have febrile non-hemolytic transfusions. We could give them Tylenol or acetaminophen to treat. If you suspect an allergic reaction where your patient complains of itching, develops hives, you could pre-treat those with Benadryl or some other antihistamine. All right, so in a previous lecture, we talked about cell saver or auto blood salvage. Remember, there are two circumstances where you would not want to use cell saver. And the number one is any presence of malignancy. So if the surgery is occurring at a site where malignancy is present and the risk for retransfusing those malignant cells back to the patient, we don't want to do that. The other one is any surgery in the abdominal area where the bowels might be involved, the risk for sepsis increases there too. So we don't want to risk the bowel being cut during the process and then bacteria be exposed, and then we give that product back to the patient. That could result in sepsis. So those are two conditions when you don't want to perform cell saver. Remember, cell saver is a very advantage is that it prevents the recipient from being exposed to multiple donors, and it prevents alloimmunization. You can do a closed system cell saver for Jehovah's Witnesses because Jehovah's Witnesses, it's against their beliefs to receive other blood products. But they will take cell saver if we can maintain a closed system. And the most often seen cases where cell saver is performed, any orthopedic surgeries where they're having a hip replacement or spine adjustment, anything like that where there could be a risk for high bleeds. Aortic aneurysms often uses cell saver, gunshot wounds, anytime there is a risk for increased blood and the need for increased donor units, cell saver is an appropriate option, except for if malignancy is present or the surgery is occurring around the bowel area. All right. How much will random platelets increase the platelet count? So remember, 1 unit of random platelets should increase the platelet count by 5 to 10,000 platelets per unit. All right. And remember what random platelets are. Random platelets are taken from the whole blood donation versus single donor apheresis, where they use apheresis to obtain a complete dose. Remember, random platelets are usually pulled together. It usually takes about 6 units to reach the therapeutic dose. All right. So single donor apheresis platelets is what is more commonly collected from donor centers now. And that's only, the only reason for that is to reduce the amount of exposure from one transfusion. All right, so let's look at each of these transfusion reactions and determine if it's related to febrile or allergic. So HLA antibodies would be associated with a febrile non-hemolytic transfusion reaction. IgA deficient recipient reacts to the donor's blood. That would result in an allergic reaction. One way to prevent that, if you have an IgA deficient patient, we would want to wash our products. And if it's a plasma product, we would want to have an IgA deficient donor. Rash and hives, symptoms of an allergic reaction. Leukodepleted products are used in a febrile. Leukodepleted products can prevent the occurrence of that febrile non-hemolytic transfusion reaction, and histamines, antihistamines, can be used to prevent allergic reactions. So now let's go through some sample intravascular versus extravascular. Several units of group A is given to group O, all right? So that is definitely ABO incompatibility that will result in intravascular. Reaction occurs 7 days after transfusion, so that is a delayed transfusion reaction, so that would be extravascular hemolysis. and that's due to a IgG antibody. IgG antibodies are associated with extravascular hemolysis. And then the most serious reaction is, of course, intravascular. May occur without prior exposure. That is intravascular. Remember, ABO incompatibility, those ABO antibodies are already established, so you don't need prior exposure. And then associated with renal failure would also be intravascular hemolysis. All right, so this is the last slide, and I wanted you guys to be able to interpret DATs. And so let's take a look. I took this chart from your textbook. Let's take a look at each of these scenarios, looking at the IAT and then the expected DAT. All right, so notice in example 1, that here's our IAT results. Screening cell 1 is negative. Screening cell 3 is negative, but we do have a 2+ reaction with screening cell 2. So this does indicate the presence of a allo antibody. It's reacting at the AHG phase of testing, so it's considered a classification of IgG. This is probably a single allo antibody. And then if we were to do the DAT, because there's no auto antibody involved, our polyspecific would be negative, so then there's no need to test further with our monospecific. So this is a negative DAT. Example number 2, notice that we have varying strengths of reaction. Every cell is positive. Screening cell 1 is 2+ at AHG. Screening cell 2 is 1+ at AHG. Screening cell 3 is actually 1+ at 37 degrees and also 3+ at AHG. So we might suspect multiple antibodies here just due to the varying reaction strengths and phases of reactivity, given that screening cell 3 reacted at 1+ and at 37 degrees and AHG. So multiple antibodies expected of IgG classification. It's an allo antibody because our DAT is negative, so there's nothing coating the patient cells there. All right, look at example number 3. Notice that we have a 1+ reaction across the board, screening cell 1, 2, and 3. So we might suspect a cold reacting antibody, an allo antibody, because our DAT is negative. All right, so there's nothing coating patient cells. And because it's reacting that initial spin, we can confer that it is a IgM allo antibody. And then example number 4, again, we have a 1+ reaction on all 3 cells at initial spin, but notice in this example, our DAT is positive. We have a 1+ reaction with polyspecific, and then we test with our monospecific IgG and monospecific C3b, C3d. Notice that it is actually complement that is causing the positive DAT, coating patient cells. So this is due to the presence of an IgM single auto antibody. And we know it's an auto antibody in this example. Even though we don't have an auto control, we know that it's because the DAT is positive. And then screening cells, in the next example, screening cells 1, 2, and 3 are all reactive at the AHG phase of testing. When we look at our DAT results, we do have a positive reaction with polyspecific, and then we have a 2+ reaction with monospecific IgG. So that does indicate the presence of an autoantibody because the DAT is positive. We expect it to be a IgG classification because of it is reacting at AHG. And so that would be a warm autoantibody because it's reacting at AHG and the DAT is positive. So this is how you can combine the IAT and the DAT to determine what type of antibody is present. And if you think about performant and elution, if you look at example number 4, where we have a room temp reacting IgM autoantibody that is activating complement, remember our panel cells do not contain complement. So because complement is coating the cells, when we do our elution and extract off that complement, our elution when ran against the panel cells will all be negative, right? Versus example 5, where we're dealing with an IgG antibody, the eluate will react with all of the panel cells, all right? So your eluate would be negative in example 4, and then your eluate would be positive in example 5. Okay, so that includes exam 4 review. I hope you found it helpful. Make sure you look at that outline that's provided at the end of module 4, and please contact me as you're studying if you have any questions about hemolytic disease of the newborn, transfusion reactions, interpretations of DATs, and autoimmune hemolytic anemia. All right.